represented by the Honorable Commissioner for Health, Dr. B. Bello, our heritage guest speaker. Please permit me to stand on the existing protocol. My own aspect of this discussion will try to bring on the point, the aspect of science, I mean science of COVID-19 in Oyo State, and how does it apply to us in the University College Hospital. And to do this, I have very few slides to discuss this. This is not to compete, well, this is not to compete with the guest speaker, the guest lecturer, but I need to share some data, some slides, some pictures for us to actually understand the aspect, of science and the science as it applies to us in Oyo State and the University College Hospital. If I can be given permission to to share these few slides, I'd be grateful. Okay. Is it shared?
Yes, you can see the slide, sir.
Okay, all right. All right, thank you very much. Well, before I go on, I'm the chairman of the UCH response team on COVID-19. Then we have a task force arm of the overall response team, which Dr. Eze oversees or coordinates, because usually there's a mix-up. Who is Dr. Eze, on COVID-19 response team, and the chairman. So I chair the overall response team on COVID-19 for the hospital, while Dr. Eze oversees the task force arm of the response team. So I need to clarify that. Thank you very much. Now, as I said earlier on, I want to discuss this and look at the implications of science and the science of COVID-19 with respect to the epidemiological and clinical decisions. Because this is very, very important for us in Oyo State and the University College Hospital. These are the highlights. Where we've talked about the NCDC, the state. I've been talking about flattening or declining curve. Is it real or apparent? Professor Tomori has actually also touched on that. In Oyo State, we've seen transition from mobile mass testing sites to static testing sites. We also discussed the implications of that. Now, the new discharge criteria from COVID-19 pathway and implications for clinical decisions also is very, very important for us as clinicians to apply the science and the science of COVID-19. And of course, I will end the discussion with the pre-surgery screening. Within 10 minutes, I should be done with this. Professor Tomori has projected this in another format. The diagram on the left is the national statistics. You can see that the testing capacity of the national level reached its peak in July. So we had the highest number of tests conducted in July, 145,455. Also in July, we had the highest number of positive cases reported, 17,457. But again, in August, the number of tests dropped from 145,455 to 121,499. And in the same vein, we also see that the number of positive cases also dropped from 17,457 to, I think, about 10,000 cases or so. So can we really call this a true decline? Because the number of tests dropped, and for me, the number of positive cases we also dropped was a function of the number of tests, which did not meet up with the previous month. So for me, I do not see this as a true decline, but I see it as an apparent decline. In Oyo State, the one on the right, the situation was also the same or similar. Oyo State has the highest number of tests conducted in June, 5,901, and in July, the number of tests conducted dropped to 5,347, and in August, it dropped to 2,427. Again, the number of positive cases also followed that trend. Drop in the number of tests conducted from June to July, July to August. Even though the highest number of positive cases recorded in Oyo State was in July, but again, we had a drastic fall in the number of tests which was conducted to almost 50% in August. And that could be responsible for the drop in the number of positive cases. Dropped from 1,380 cases in July to 358. And for me, again, I cannot take that as a true fall, as a true decline. A true decline, I want to see the number of tests to continue to rise beyond 5,000, 6,000, 7,000 on your state, and also to continue to rise at national level. While the number of tests being conducted continues to rise, then the number of positive cases should be falling. Then that we can say that there is a true decline. So this is an aspect of science, because this can be misinterpreted as as if we are getting out of the pandemic, and that can lead us to making some wrong decisions. But before I leave this slide, I want to say that yes, even though I've talked about these statistics, but again we can see that the epidemic curve, both at the national level and at the Oyo State, do follow the propagated epidemic curve, which is expected of this kind of pandemic, propagated epidemic of COVID-19. And I want to believe that based on the recorded fall of number of cases, then the task force in Oyo State, was already using those statistics to take certain decisions. And that's the aspect of science, which Professor Tomori has talked about. The curfew has been lifted, and not only that, the isolation centers which were being established in different aspects of the state, so are already being converted to isolation centers. So using some wrong statistics to take this kind of decision, to me, is an aspect of science. Yeah, I'm bringing up this again. For Tomori has highlighted the statistics up to date, but again, I'm bringing this up to tell us that COVID-19 infection and deaths are still with us. These are the deaths which have been reported in the last 1 week, from 1st of September to midnight of 7th of September, we have recorded about 48 confirmed COVID-19 deaths. For me, this is huge, irrespective of the denominator. So COVID-19 is still here with us, and we should not begin to throw away all the preventive and control activities that we've been doing. And not only that, infection rates continue to rise. In India, the graph is still rising. Same in South Africa. In United States of America, so the graphs continue to rise. So we cannot, and Nigeria is part of the global community. And of course, we're all aware that aviation industry has reopened. So this, with the statistics and with the rising number of cases in the different, areas of the world. So opening up of the aviation industry, really constitute a single largest threat to us in Nigeria, even though we are seeing, we're already winning. The opening of clubhouses, private universities are already agitating that they are ready to reopen, and of course, many other stakeholders have also, been talking about schools and universities to resume. So these are immediate threats to where we are in Nigeria and in the state. Now, for those of us in the University College Hospital and the state, I want to bring this up to attention that Oyo State has actually moved from mobile mass testing to static testing. And I think there are about 9 testing sites which Oyo State has established. University College Hospital, we have one, Ring Road State Hospital, General Hospital, Health is Wealth Clinic at the Secretariat, outside Ibadan. So we have this, we have testing sites in these hospitals. So the message here is that, yes, our patients do not need to come down to UCH to have their tests done, particularly those of us who still want patients to do pre-surgery screening. So we can actually direct patients to visit any of these testing centers in Ibadan and outside Ibadan, depending on which one is close to them. So we can direct patients to go for testing at these sites. But moving from mass testing to static testing sites, I've come up with some implications. We have observed that the drive-by testing enthusiasm is lost. When mass testing was being done mobile from one place to the other, you see large number of people coming out to get themselves tested. And this is typical of outreach mobile health activities. We also see that in outreach, immunization, community cataract surgery, and all that. So these usually attract large clients than static sites in hospitals, and that have been responsible for the large number of tests which were conducted in July. So again, we also see that publicity has drastically reduced with the transition to static testing. Of course, we know that this kind of approach is cost saving, and of course, we also begin to see some levels of fatigue at the political level. Then the technical staff, the technical team, it's also showing some also showing some fatigue. Now, I want to quickly discuss the new discharge criteria from COVID-19 pathway, again, using the science, the new science that we know about the virus. WHO came up, I think about 2 months ago or less, to say that a negative PCR, yes, a negative PCR is conventionally used to discharge a patient. The new information that we have, new evidence that we have now has told us that viral RNA detected beyond 10 days is no longer infectious because no viable virus is grown in the culture. So this is new evidence about the virus. And we want to, where this science has been established and the hospital has actually begun to make use of that evidence with respect to clinical decision. Okay, there's also some evidence that reinfection cases who became PCR positive after discharge have shown known evidence of transmission to contacts and no detection of the viral replication through viral culture. So these are new bits of evidence, which, and of course, they have implications for us as clinicians. What it means is that a negative laboratory test is no longer required to discharge a COVID-19 patient, and that symptomatic patients, after being free of symptoms for at least for about 3 days, 10 days after onset of symptoms, and with the SpO2 consistently, at 95% or over in a room here temperature in room here for 3 days, such a patient can be discharged from COVID-19 pathway. So this is new information, this is new science that we know about the virus. Again, the guidelines also talks about asymptomatic patients can be discharged from COVID-19 pathway 14 days after the initial positive result. So these are new evidences, new science that are just, come up about this virus. And we have actually started to apply this science to clinical decision. Now, staff members, we request, or we ask staff members to return to work without a negative test result. So we are bringing this to the attention of heads of departments and colleagues so that they will not be requesting for a negative COVID-19 test from their staff before they return to work. Again, our colleagues, surgeons and anesthetists, should also know that patients do not require a repeat test as a precondition for surgery after satisfying the criteria of asymptomatic patients 10 days after onset of symptoms and 3 days without symptoms, of 14 days after the positive result. From the evidence of the viral that we have on the virus. So these are new guidelines from WHO, and which the NCDC, the Nigerian Center for Disease Control, also was asked us to implement. So these are new bits of information that we want to pass. It will be difficult, maybe to accept this, but again, we should, be able to, to begin to apply the knowledge of science that we know about the virus, apply it to the clinical decision with regards to our patients. Yes, even though we've talked about all that, then as a note of caution, NCDC, still asks us to be cautious, that yes, even for those patients or staff members who satisfied those criteria, so the usual NCDC guidelines on hand hygiene, social distancing, use of face masks, adequate hydration, and of course multivitamin supplementation should continue. So we will continue to implement this. And of course, another new information that we have is that there's no sufficient evidence that SARS-CoV-2 is found in semen and breast milk. So these are another information that we want to pass across. Yeah, I want to conclude this short presentation by just saying that yes, because of the reduced testing, and that no repeat test is no longer required for previously positive patients. So we want to see, of course, we are beginning to see a situation where our laboratories are now less burdened by, high number of samples. And we want to believe that because of that, resources are being freed, and we've started engaging the Communal Laboratory on the issue of pre-surgery screening for COVID-19, which helps us to stop that previously. So we've already started engaging the laboratory again to see how we can recommence the pre-surgery screening for COVID-19 patients, so that you don't have to send patients out of UCH looking for where to do pre-surgery screening, even though that may come at a price for the patient. So we already opened the discussion with the laboratory, and as soon as we're able to conclude, we will let the hospital community be aware of that. So I thank you for the attention. Thank you very much, sir.
Prof, for the excellent presentation. Enjoyed it. Professor Osungbade will comment on the comment of Dr. Okedare. He said he has a patient who is still positive at 3 months, and whether we are dealing with a variant. But based on the presentation by Professor Osungbade, do you want to make a comment, or Professor Tomori, on that?
Well, thank you very much. I actually noted that question, but unfortunately I forgot, when, I was presenting. We've also had, I think, 1 or 2 similar experiences here in UCH, where we had, I think 1 or 2 patients, who continued to, return positive for 6 weeks, 2 months, and all that. And they were worried until, but again, that was then. We waited until, they, returned negative before, they were discharged from COVID-19 pathway. We didn't have this information at that time, but now we don't wait until then. So that patient or that person, who continues to be positive, 3 months after, from the evidence, which WHO and its national community has provided for us, that yes, even though the virus, is still being seen, the virus is no longer infectious, and of course, such a patient, can be asked, to return to the community, can be asked, to go about his normal life. Thank you very much.
Professor Tomori, sir, do you want to make a comment